Our next speaker has a strong history of service to the nursing profession. Graduating from Butler County Community College and the Wesley School of Nursing, Paula has dedicated her career to the world of oncology nursing, obtaining her O.C.N. in 1986. She has been an active member of 24 different committees, provided more than 65 professional presentations, is a member of multiple societies, including local and national chapter of ONS, the National Association of Vascular Access Networks, Infusion Nurses Society, and the Association of Community Cancer Centers. She is an active participant and board member for Victory in the Valley in Wichita, Kansas. She serves as the Chief Nursing Officer for the Cancer Center of Kansas and is a continued mentor and inspiration for the oncology nurses that she works with. Thank you very much.
Thank you, Maggie. I was so excited to be asked to speak today. And it was kind of funny because Maggie called and she said, you could come and see what the research world is like. And I had to laugh because I said, well, you're so young. If you'd go back to the archives, back in 1983, I started in oncology nursing. And yes, I know you weren't born yet. But, you know, you'll see my name in the books. Along with Dorothy Coleman, she's here, and I've already seen her, and Debbie Christie. I laughed when they called her the historian. Yes, we are old. But we have perspective, and I think perspective is good, and that's what I hope to instill in you today. And we're going to talk about, you know, the role of the nurse, because I feel like that, and I apologize if there's any physicians here, the role of the nurse is so important for these patients. And we're going to talk about how we can improve on patient adherence. And I thank Dr. Henry for kind of her segue into this, because I think when you look at drugs today and the side effect profile, it's so much different than what we've been using before. So we need to have new tools. We need to have new ways to help our patients. So we're going to look at the perspective of just the advances in oncology treatments and talk about some of the evolving issues. And I think the change is happening so rapid. If you look at how many drugs are coming out on a regular basis, every week there's at least 2 or 3 new FDA approvals. So how as a nurse are we going to keep up with this information, and how are we going to help the patients to be able to get through these side effect profiles on these new medications? And so the role of the nurse, I think, is very important. We're the one that gives the patient the tools to go out and to be able to know the side effect profile of these drugs, to know how to live actually with these medications. So we're going to look at some strategies. And I'm a big ABC fan, so I'm watching these television programs. Of course, The Bachelor, I think, is one that gives us all lessons in life to live by. And so at the end of this discussion, I'm going to reveal the most dramatic information ever on how to get your patient to stay with the adherence. So compliance, what is that? I mean, when I told people that I was going to talk on patient adherence, they're going, okay, so what is that? So compliance is a way to, it's a way to say that we're being less judgmental than adherence, because it's how consistently the patient stays on the medication as prescribed. And when you seriously look at this, I think this is part of the big problem. Because when you're prescribed a medication, even yourself, if you're taking some type of medication, how often do you take it like you're supposed to? You know, your rule is whatever works. And so as we're now moving to these PO medications, how are we going to get the patients to take the medication as prescribed? And then how are we going to know if they're actually, how much they're actually taking it? And so we've done all of these studies. You guys work diligently to get these drugs to FDA approval. And then the patient is taking this medication, and he doesn't have a research nurse calling him every week saying, hey, how are you doing on this? They're pretty much left to their own device, or demise, I would say, and most of these newer medications, on how they're going to stay on it. So we're looking for persistence. We're looking for how the patient is going to stick to this medication over time. As I think about myself, and I take Toprol and Synthroid, and I'm supposed to take this on a daily basis. Okay, it's the same as, I took a poll the other day before I came of how many people were on regular medication and how often they take it as prescribed. And you'd be amazed at the number of people that walk around with pills in their pocket. I had two. I had my Toprol and my Synthroid because I hadn't had my coffee yet, and so I was waiting for that. Sometimes, you know, I switch it to the other pocket because it's falling out with my phone and rolling across the floor. Or, you know, you do things just to make it work. Sometimes at the end of the day, I'm still with the Toprol and Synthroid in my pocket, so I'll lay it, you know, out as I take my jacket off so that I don't get it in the washing machine, which I've done, and now have white stains on a couple of my lab jackets. Or I wait till 7 o'clock when my heart rate goes to 120, and then I truly know, oh crap, I didn't take my medicine. So this is just a regular medication, not something that is truly going to save my life. So do patients who are on medications where actually that is the long-term goal, do they actually stay on the medications? So now we're in this time of change where before we had the patient coming into the clinic every week or every 3 weeks. We were into chemotherapy and the cell cycle, and so that's how those medications were instilled. And these patients then got to talk to the nurse, got to see how they were doing with their side effects. They were given advice and given more time to go out and, you know, be on this medication. In fact, I had one patient a couple of weeks ago who I was standing at the nurse's station, and the patient was falling asleep in the chair, and he kept falling forward. And I went over to the wife and I said, can I do something to help him be more comfortable? And she said, no. She said, actually, when he's here, he has a sense of relief and he feels safe. And so he hasn't been sleeping well lately, and so when he comes into the clinic, he falls asleep right away because he's so tired. And I think that's kind of true of, you know, what has been our role in the past is to help these patients with adherence and to help them to be able to make it through the treatments. And at Christmas time and at, you know, all of these special events, the nurse is the one that gets all the candy. Well, why is that? You know, the business office is like, well, why aren't they sharing? You know, it's not that the business office isn't any more important, but it is the nurse who these people feel like truly made a difference in their life. And so I think we're going to kind of be, you know, put on the back burner if we don't come up with some ways to really be there for these patients as they're on PO medications. So it's not just a trend. This is going to be a seismic shift. If we have 50 medications that we have that patients are supposed to take on a regular basis, how are we going to give them the tools to make the difference? Now, this is a picture of Dorothy and Debbie Christie and I traveling to an oncology meeting. I laughed when I saw this. I thought, you know, people really do come up to me and tell me how old I am, and I really don't feel old. But when I think back to, you know, our earlier days in oncology, you know, it's all changed, but not a lot has changed. We're still the pioneer women. And so as this is a new development, we're going to have to come up with ways and tools to help these patients. So way back in the 80s, it was looking at nausea. I mean, we had to be very quiet in the clinic because we actually sedated the patients and gave them, you know, high doses of drugs to get them to sleep so that they were not nauseated. And if you woke up one patient, it was throw up, throw up, throw up as they go down the row as these patients all woke up. And so then came along Zofran and Aloxi and a lot of symptomatic care drugs that I really feel like that the nurses played a big role in helping to develop these drugs so that we do now have much better symptomatic care for our patients. But what are we going to do for the patient who's home and developing a rash? Or something like Feridac, where that patient is going to be getting serious diarrhea, or, there's a whole multitude of drugs. I'm going to try not to say medication names because I don't want to feel like I'm endorsing anything, but there are so many new medications out, and the side effect profile is monumental. So we are the pioneer spirit, and we are the nurses who are the ones that are going to help to develop these new medications or new inventive ways to help these patients. So when you have a patient speaking to the physician, I really feel like that I'm not trying to, lessen the physician's role. He is the one who is determining the drugs. It's very sequential now, and it's very orchestrated that these patients remain on medication. And if you listen to some of the experts, they talk about these patients now, the more that they can adhere to the medications and stay on the medications, the better the prognosis. So that's his role, is to determine where we are, what we're doing, and to help the patient at that point. But then the patient, how many times does the patient come back to the treatment room and you say, okay, so, you understand what we're going to do, and they're just clueless. They didn't hear anything past the first few words. And so it's the nurse who then, I call it, translates what the physician said, puts it into an easier term for the patient so that they then know how to, help prevent the side effects, when they're going to be here, all of those things. But as we're in this seismic shift, now the physician sees the patient, he prescribes the medication, it goes to a specialty pharmacy, they're sometimes seen by the nurse practitioner, or, there are other methods. It's kind of happening all across the United States, just as in the past, but each place is trying to reinvent the wheel, trying to figure out how they're going to help these patients with adherence, what are the things that we're going to do. But I feel like it's so important that we do translate for these patients. And I always ask the patients, and that's one of my roles as we first started with the PO medications, was to be the one that did the education, because it really didn't fall in anybody else's role at the time. And so it was very interesting as I started, because the physicians said, well, we'll talk to them in their office visit about their medication, and we'll give them the prescription. And I said, but somebody needs to provide education. And they said, well, we'll give them the information. Well, as you call these patients to find out what they do know, you spend at least 15 minutes on how am I going to take this medicine? Because they can't even get past the first hurdle, which is on an empty stomach or not on an empty stomach, or how is this going to be molded into their everyday life so that they are going to take the medication appropriately, not carry it around in their pocket. So when we have moved from cell cycle to pathways, and we have all of these targeted medications, this is what's bringing these PO medications to light, is that we're now learning so much more. And if you've gotten a chance to watch The Emperor of All Maladies or read that book, so interesting. It's like we're going, it's the history of oncology truly, and how we are to the place that we are. And we are in such an exciting time right now where we feel like, we're getting very close to some very big answers. But when we're looking at how these new medications are working, it's not cell cycle specific so many times. It's more that we're trying to target a pathway. And so we're trying to identify the target, we're trying to identify the mutation, and then you can see that there are so many pathways. This is not to plug any drug, but this is just one of the examples of a a pathway, and are you going to hit the main fuse box of the cell? Are you going to hit the mTOR? Are you going to hit some other pathway to try and stop this tumor? And now we're looking at the immune system and trying to go kind of back to the basic body functions and to learn what has caused this cancer and how we're now going to start to target it from a different line. So there are so many medications in the pipeline. There are so many oral agents that are coming out. Like I said, I counted 50 just in my files of new medications that are PO. So that patient is now maybe still getting some IV medication, or they're just totally on a PO medication. So yeah, it's great. They're going to spend less time in the doctor's office, less time in the waiting room. They're going to feel like that, this is something now that is hopefully going to be helpful, give them a sense of empowerment. But there is that less communication time with the nurse and the less education in the decision making. So many times I talk to the patients and their decisions are based on their social life. I've got a wedding to go to next weekend, and this medicine makes me feel this way, so I'm going to hold it and start taking it again on Monday. So when we had patients in clinical trials, and the nurses were calling, and we did have what we knew to be adherence, then we got our statistics based on that. But what's going to happen now as the patient is now out there taking the medication? I fear that we're going to see some difference in statistics. And just an example, I had a nurse tell me that she had a patient on study, and the patient had blister packs, and the patient brought the blister packs in. Yes, she'd taken the medication. She handed her the empty blister packs. And then the physician looked at the results of all the lab testing and everything, and he said, well, I'm sorry, but there's clearly evidence in progression of disease, and we're going to have to refer you for a transplant. Patients really said very little, left the office as they were starting to try to organize all of the appointments and everything, and the patient called back in and she said, okay, I have to confess, I didn't take the medication. I started taking it, and I didn't like the side effects, and so I just punched all of the drugs out of the blister pack and brought them back in. So can I still be on the study? Can I start over? It's something that I think we are going to be dealing with in one way or another. And I feel like that, like I said, the patients that were on study were so much better monitored, had the nurse role of someone routinely watching them, and that they were kind of measuring the outcome on a more regular basis than these patients that are now just being prescribed PO medication. So less frequent assessment, possibly less interaction with other patients, and the cost. The cost is now something that, as we know, these drugs are astronomical. There's a whole committee just to help when we're prescribing these medications, to help the patient to determine how they're going to pay for this. So now we're going to be looking at non-adherence, something that really we didn't discuss a lot when patients were on IV medication, because the patient was coming in every week. You knew the patient was there. You knew down to the milligram how much medication that patient got. So we truly knew from our statistics what our results entailed. So are we going to have compromised disease outcomes? Is it going to change survival, time to relapse? All of those things are things that I think are going to have to be strongly looked at as we have this seismic shift. And so what, as an oncology nurse, can we do to improve oral adherence to therapies? So you look at the definition of adherence, and it's keeping to the scheduled appointment, taking the medication, following dietary changes, lifestyle changes, following preventative measures. All of these things are all wrapped up in things that within a short period of time you have to go over with the patient just to make sure that they understand. This has got to be on an empty stomach. What does an empty stomach mean? Does that mean with my coffee? Can I take the rest of my pills when I'm taking it on an empty stomach? All of these things have to be defined. And I think, the tools that we move forward with have to really be very explicit and very simplistic for patients. And as I talked about monitoring compliance, pill counts, patient reporting, patient diaries, all of these things are out there. If you look at websites, there's the ACCC or the Oncology Nursing Society. They've all developed tools that are out there now that we're starting to use for how we're going to monitor compliance on these patients. And you can use podcasts. I think someone was talking to me about virtual appointments where you could, they're looking into the future. Can we have appointments with these patients on some type of iPad or, some type of using the computer to help meet with these patients so they didn't have to come into the clinics. But you can see that there's a whole laundry list of things that can be used. But it all boils down to the same thing. You've got a very short period of time, and you have patients who are probably listening only past the first side effect. When you start talking about the severe rash or the diarrhea, you can see the wheels turning, and they're already not listening to what you have to say. And I think the other problem is we've given them so much information. You deluge them. When you give them the consent form, and then you give them all the stuff about their office visit, and then you give them the written information about the drug and the side effect profile. And where does that go when they take it home? Do they throw it over in the corner, or is it something that they're actually going to use? And we at the Cancer Center tried to develop a tool that is very one page, but goes through how often they take the drug. And I think that's our first conversation, is when are they going to take it? And then when do you, how do you report the side effects? Or when do you know when to call? So these people sit at home and they try to determine, when should I call? And I've kind of developed a little method, and it's called weirditis. So the patient, I say to the patient, okay, you're going to be on this new medication, and you're going to have some side effects, and you're going to, see these bumps on your arm or something, and you're going to go, hey, that's weird. And, who do you have to talk to? Not really anybody. So then what do you do? And so, we've given them a list of things to try. So I want you to try these things on this sheet of paper. And when you develop weirditis, that's when you need to call. And so how do you define weirditis? Well, it's when it really actually is impacting you, like it's causing you stress, this itching that won't go away. Or say you have diarrhea and you're to the point, it's been 24 hours, which we've defined on the paper, and you're not able to function anymore. You're starting to feel like you're dehydrated, or maybe you're running a fever. It's when you get to the point of weirditis, I definitely want you to call that day. And we have exactly who to call, what numbers to call, how to get a hold of the physician if you can't get a hold of the nurse. And so, that's starting to filter through now to the phone calls, and the nurses are getting these weirditis phone calls, which at first I forgot to tell them, oh, by the way, this is what I'm telling the patients. But it is working because, most of the time, if you look at the side effects, like Dr. Henry was describing on, that medication, how does a patient determine when this is too much? When do I need to notify the physician? So it's developing concise and easy tools, which sounds like a duh. Okay, yeah, we do that all the time. We're always making tools. We're always, as nurses, trying to reinvent the wheel, and have medications on hand, and have it clearly defined when to take the medication, when to call, who to call. And so the goal is to keep the patient on the drug. And you'd think that that would be an easy task. You'd think, okay, here you go, here's the medicine. But if you even just read the black box warnings on some of these medications the patients are taking in pill form, it's enough to, scare you. And these patients are very apprehensive. And so having somebody to talk to, I think, is the key to the whole thing. The physician's involvement should definitely be kind of the start of the conversation. He's going to talk about where we are in this disease process, why we've reached the decision to use this medication, discuss adverse events and any drug interactions. And then, the patient is then like, huh, okay, I guess I get it, But then that's where the true nurse involvement comes in, educating the patient, talking about what medications they have on hand. If you have a patient that's got a possibility of severe diarrhea, you're going to definitely want to make sure that patient has Imodium AD, and they have it the week before so that they're not left to deal with that on an emergency basis. Who to call, when to call, how to get refills, side effect prevention, all of those things are there. And I think this is probably the biggest key: follow up with these patients, ongoing conversations about how they're doing on the medications. And that's going to vary from clinic to clinic on who's going to be doing the follow-up and how that's going to be handled. And as we've talked about, there are so many barriers to care, and I think we have to figure out how we're going to improve on this, because as these patients go forward and there are so many PO medications, this problem is definitely here to stay. And the social history, I think, enters into it very often. Who comes with the patient to learn about the medications and the side effects? And what are their feelings? If they feel like that this is something that's not going to work, or that they have their own strong opinions, it is definitely going to influence the patient and how he takes the medication. So this is the ta-da moment, and it's kind of like when you're watching The Bachelor or something, and they go, "This is the most dramatic ending ever," and then you go, "Well, that wasn't so dramatic." Well, guess what? This isn't that dramatic either. It is just saying that as we move forward, it is a team approach, and it is something that we're going to have for a long period of time. We're going to have to determine how each member of the team fits into this and how we're going to help these patients to stay on target with their medication. As I said, the Oncology Nursing Society has a great toolbox for oral adherence. And I saw through the ACCC they were starting to, they have something on their website so that there are tools if you're developing in your clinic anything for the patient, patient education specific, or for directions on how to take the medications. There are a lot of tools out there that I think definitely the patient needs something in their hand as they leave to take home with them so that they can stay on the medication. Do I have any questions? I have to tell you my funny story. I had a gentleman come in, and I don't even remember the medication that he was supposed to be on, but he was probably in his 80s, and I started to talk to him about the rash, and I said, now one thing that would help is if you would put lotion all over your body. So after you take your shower, get some type of lotion that's very thick emollient and just rub that all over your body. And he goes, all over my body? And I said, yes, all over your body. All over my body? And I said, yes, all over your body. Okay, well, I don't get it, because I said, I know you've never used lotion before. And he goes, no, I've never used lotion in my life. And he goes, I was kind of afraid where he was going, but I didn't want to go there. He goes, and literally he said this 10 times, because the girl next to me counted it. And he couldn't get past that. I mean, you know, I was trying to go over other things with him, but he just kept going, I've got to apply lotion all over my body. And so as he left, he turned around and he looked at me and he said, all over. So it's kind of a running joke about the lotion and all over your body. But it just shows you, you know, for every different person, you know, it's going to be something. And you're going to have to help them determine what that something is and try to help them get past that. So I was thinking about maybe that I would call him this next week just to check on how it was going with his lotion. Thank you.